Good afternoon, students. Today we are going to discuss about the three topics. That is, the first one is the biliary apparatus, especially the extra-hepatic biliary apparatus. Then thoracoabdominal diaphragm. Thoracoabdominal diaphragm. And next is the peritoneum. What is peritoneum? What are the different segments of the peritoneum? And all these things we discuss. First, we discuss about the biliary apparatus. The biliary or excretory apparatus of the liver includes the passages through which hepatic bile and gallbladder bile are conveyed into the second part of the duodenum. Here, the parts which are included in the conveying the bile from the liver or from the gallbladder into the second part of the duodenum. That is, the structures which are involved, they are called biliary apparatus. Biliary or excretory apparatus. Biliary or excretory apparatus. That is just like our kidney. If you take kidney, there is a glomerulus, nephron, and PCT, DCT, like that. And the outside there is a major calyx, minor calyx, and finally together they form the ureter. Okay, like that. Here also there is a excretory apparatus in the liver. This is meant for to convey the excretions or bile which is secreted in the liver into the second part of the duodenum for the purpose of emulsification. For the purpose of emulsification of the especially fats. Emulsification of the fats. For this purpose, there is a special arrangement. That arrangement is nothing but the biliary apparatus. Biliary apparatus. Okay. Here, for our convenience, we are dividing the biliary apparatus into two parts. That is, one is intra-hepatic apparatus and extra-hepatic. That is, intra-hepatic is within the liver, within the substance of the liver. There is that system that we call it as intra-hepatic biliary apparatus, and outside the liver, that is coming out from the liver, that is from the hilum of the liver, the structures coming out, they are called extra-hepatic biliary apparatus. Extra-hepatic biliary apparatus. You see here, what is this one? Already you know, this is the nothing but the yellowish discoloration of the sclera. It is jaundice. It is due to jaundice. Here, what is the purpose of knowing about the biliary apparatus? That is, whatever you know, is it intra-hepatic or extra-hepatic? What is the purpose? To understand, to treat, to diagnose. What is the cause for the different clinical conditions which are related with the liver and biliary apparatus? Biliary apparatus. And what are the relations? What are the structures? What are the probable causes? All these things we are supposed to know. Okay, for this purpose, we are studying about the biliary apparatus. In our physiology and in our biochemistry, already you studied about the jaundice. Jaundice is nothing but the symptom. Jaundice itself is not a disease. Jaundice is not a disease, it is only a symptom. But because of the jaundice, we are supposed to know, we are supposed to diagnose what is the cause, why the person developed jaundice. There is some underlying cause for the development of the jaundice. If you want to understand, if you want to diagnose, if you want to treat the underlying cause for the jaundice, you are supposed to have an idea about the biliary apparatus, whether it may be intra-hepatic or extra-hepatic. Okay, for that purpose only we are studying. Okay, not only jaundice, there is changes in the liver functions. That also most common clinical conditions. Okay, to understand what are the diseases which are related with the gallbladder, diseases related with the CBD, that is common bile duct, diseases which are related with the liver function and liver cytology. All these things are very, very important clinically because these are the routine clinical conditions we are exposing in our clinical practice. Because of this reason, the proper idea about the biliary apparatus, especially what are the structures which are taking part in the formation of the biliary apparatus, and it is very, very important clinically. For this purpose, we have to know about the biliary apparatus. Okay, first we see intra-hepatic biliary apparatus. That is, it contains what are the structures which come under the heading of intra-hepatic biliary apparatus. That is, first we see biliary canaliculi. Biliary or bile canaliculi. Next is the canals of Herring, and bile ductules, and finally all these bile ductules together they form the right and left hepatic ducts. These right and left hepatic ducts they drain the two physiological lobes, that is right and left lobes of the liver. Okay, clear? What are the structures which are in the consists of in the intrahepatic biliary apparatus? That is bile canaliculi, canals of Herring, bile ductules, and right and left hepatic ducts. Okay, you see here, this is the hepatocyte. And this is the nucleus, and it is having 6 sides. Hepatocyte is having 6 sides on 4 sides. 4 sides of the hepatocyte, they are surrounded by bile canaliculi. This is nothing but the bile canaliculi. The remaining 2 sides, they are related with the hepatic sinusoids. Okay, here the bile canaliculi they are formed, then they drain into the bile ductule. This is nothing but the canal of Herring. Next, this is the bile ductule. These canals of Herring they are formed by the union of bile canaliculi. These are all the piles of hepatocytes. And this is the space of DC, space of mall. Okay, already you know. We were discussing about the liver, we discussed. But here, this is the canal of Herring. This canal of Herring joined with the bile ductule. And all these bile ductules together, they form the right and left hepatic ducts. Okay, right and left hepatic ducts, they come out of the substance of the liver and they enter into the porta hepatis. That is just like a hilum of the liver. Porta, just like our lung, just like our kidney or spleen. Here also it is a port of entry or exit. That is called porta hepatis. Hepatis means liver. Porta means port. That is the entry point or exit point of the liver. That is nothing but the porta hepatis. Here, the right and left hepatic ducts, they comes out of the substance of the liver and they enter into the porta hepatis. Within the porta hepatis, these right and left hepatic ducts together, they form the common hepatic duct. The common hepatic duct, it is the first part of the extra-hepatic part of the biliary apparatus. Okay, common hepatic duct is the first part or starting point of the, that is starting part of the extra-hepatic biliary apparatus. Okay, then the common hepatic, here what are the contents of the extra-hepatic part of the biliary apparatus we see now. Okay, first is the common hepatic duct, then gallbladder. Next, from the gallbladder there is another duct that is called cystic duct, and next is together the cystic duct and common hepatic duct together they form the another duct that is bile duct, or this is also called common bile duct. CBD, common bile duct or bile duct. Okay, first there is a common hepatic duct. Hepatic duct is formed by, common hepatic duct is formed by the union of the right and left hepatic ducts. Together they form the common, it is called common, these two joining and they are forming the duct, that is why it is called common hepatic duct. Next, from the, we attach it to the common hepatic duct, there is another structure that is nothing but the gallbladder, and from the gallbladder also there is a one duct that is nothing but the cystic duct, and these together, common hepatic duct and cystic duct together, they form the common bile duct or bile duct. CBD. CBD. This is very, very important clinically. You remember. Okay. Next, you see here, this is the picture. It shows entire extra-hepatic biliary apparatus. Okay, it shows entire extra-hepatic biliary apparatus. You see, this is the left hepatic duct. This is the right hepatic duct. Okay, this one. This is the left. This is the right. Together, they form the common hepatic duct. This is the common hepatic duct. This is the left hepatic duct. This is the right hepatic duct. Together, they form the common hepatic duct. Then this common hepatic duct joins with the cystic duct. Together, they form the common bile duct or bile duct. This is also called. This part is called CBD. The CBD is very, very important clinically because while doing cholecystectomy, this removal of the gallbladder, the CBD, you must spare that CBD is very, very important. Sparing of CBD is very, very important. Otherwise, it may lead to its clinical manifestations and complications. That is why the knowledge of this total extra-hepatic biliary apparatus clinically is very, very important, especially for the gastrointestinal surgeons. Gastrointestinal surgeons and general surgeons also. For general surgeons also. Okay, it is very, very important. You see, this is the left hepatic duct. This is the right hepatic duct. Together they form the common hepatic duct. The common hepatic duct, here the common hepatic duct length is 3 centimeters. 3 centimeters. The caliber is 4 millimeters. 4 millimeters. The common hepatic duct caliber is 4 millimeters. Length is 3 centimeters. 3 centimeters. 3 centimeters. This is the 4 millimeters caliber. And here, this is the, what are the relations of the common hepatic duct? You see, posteriorly there is a inferior vena cava, sorry, superior vena cava, portal vein, and on the left side there is a common hepatic artery, and in the left side cystic duct. Okay, this is the common hepatic duct. It joins with the cystic duct. The length of the cystic duct is 4 centimeters and the caliber is only 2 millimeters. 2 millimeters. The caliber of the cystic duct is 2 millimeters. The length is 4 centimeters. 4 centimeters. Together they form the common bile duct or bile duct. The caliber of the CBD or common bile duct is 6 millimeters. 4 plus 2, 6. Okay, 6 millimeters. And the length of the common bile duct or bile duct, that is about 7.5 centimeters. 7.5 centimeters. That is the length of the common bile duct. Okay, here the common bile duct, we are dividing the common bile duct into different parts depending upon its relations. First one, this is the supraduodenal part, and this is the first part of the duodenum. This is the second part. Okay, third part and next fourth part. Okay, here this is the first part of the duodenum. Just behind the first part of the duodenum, there is some part of the bile duct that is called retroduodenal part. And below the first part of the duodenum also there is some part. This part is called infraduodenal part. And then within the wall of the second part of the duodenum, here also there is some part. This is the intramural part or intraduodenal part. This is about 2 centimeters. 2 centimeters. Total is 7.5 centimeters. The length of the common bile duct or bile duct. The caliber is 6 millimeters. The caliber is 6 millimeters. Okay. Next, here this is the cystic duct. Then connected to the cystic duct, there is a pear-shaped structure and slate-colored structure. This is nothing but the gallbladder. The capacity, the length of the gallbladder is 7 to 10 centimeters, and the capacity is 30 to 50 ml. Capacity of the gallbladder is 30 to 50 ml. The maximum breadth is 3 centimeters. 3 centimeters. Length is 7.7 to 10 centimeters. It is highly variable depending upon the individual. Okay, this is the gallbladder. Here, the gallbladder is having different parts. That is, this part is called fundus of the gallbladder. This part is called body of the gallbladder. This is the called neck of the gallbladder, and this is the from here. Neck is S shaped. Neck is S shaped. Then it continues as the cystic. These are all the different parts of the gallbladder. That is fundus, body, neck, and cystic ducts. Okay, these are all the parts. Here, out of these, the fundus is covered by peritoneum in all its sides. All its sides is covered by peritoneum, but the body, neck, they are covered only inferior surface. The superior surface is accommodated in the fossa of gallbladder, that is inferior surface of the liver. Because of this reason, it is a extra-peritoneal. It is extra-peritoneal. Only the inferior surface of the gallbladder is covered by peritoneum. It is covered by peritoneum. Okay, this is the gallbladder. Here, what is the function of the gallbladder? You know very well about the gallbladder, and what is the function of the gallbladder? That is storage of bile. And here, the gallbladder bile is 10 times more concentrated than the liver bile. That is, to perform this function, the mucosa of the gallbladder, it is having a specialized lining epithelium, that is columnar cells. They are having absorptive function. They absorb the water, which is excess water which is present in the bile. Then they concentrate the bile. Because of this, there is a chances for the formation of gallbladder stones or polylithiasis. Polylithiasis, that is nothing but the formation of stones in the gallbladder. That is the most common clinical condition. And here again, this is more common in the pale, fatty, after 40, fertile female. It is more common in the that means there is no chances of formation of gallstones in the male. Not like that. Okay, the chances for the formation of gallstones in the male also, but it is more common in the females. 5F, female, 40, after 40, fertile, fatty, like that. Okay, here that is the gallstones. If there is a formation of gallstones, gallbladder stones or polylithiasis, it may produce its own manifestation, that is pain in the right hypochondriac region, especially at the tip of the ninth costal cartilage. That is the location for the fundus of the gallbladder. Fundus of the gallbladder that corresponds with the that is mid-clavicular line. That is corresponds with the mid-clavicular line. That is the area for the gallbladder, fundus of the gallbladder. If you feel like this, if the person is having complaint of pain or tenderness at the tip of the ninth rib, that means he is suffering with the polycystitis. It produces tenderness. That sign is called Murphy's sign. Murphy's sign positive means there is a chances for the, not mostly that is a person, especially pain in the upper quadrant, that is right costal margin, below the right costal margin, that is our right hypochondriac lesion. If there is pain in the right hypochondriac lesion, the Murphy's sign is positive. That means the person is suffering with the polycystitis. It may be due to infection or it may be due to formation of stones. That is why this gallbladder is very, very important clinically. Okay. Then there is another special area. This is nothing but the Calot's triangle. Calot's triangle. This Calot's triangle clinically is also very, very important, especially during the polycystectomy. You must be very careful with the Calot's triangle. Okay, we discuss what is Calot's triangle. Then here the common bile duct, then it opens into the second part of the duodenum. Along with the pancreatic duct. Here surrounding these ducts, there are sphincters to regulate the flow. of the, that is secretions from the pancreas and secretions from the liver and gallbladder. And there are ducts. These ducts are regulated with the help of some sphincters. That is the sphincter which regulates the bile duct. That is called sphincter choledochus. It is also called sphincter of Boyden. This is sphincter of Boyden. It is very, very important clinically because it resists the continuous flow of bile into the second part of the urine. Okay. Here it produces, it resists up to the level of the 20 millimeters of mercury pressure, 20 millimeters of mercury pressure, and it resists. Then if the pressure is more than 20 millimeters of mercury, then only it allows the, or it pours its secretions into the second part of the urine. This pressure, this wall, it is sphincter is very, very important, because if there is increase in the tension of this bile in the gallbladder, there is increase in pressure in the gallbladder, and it constricts the gallbladder constricts, it increases that pressure. Then only the sphincter of Boyden opens. Then it allows the entry of this secretions into the second part of the duodenum. And here this stimulation it receives from the cholecystokinin. It is secreted by the, that is duodenum. It is secreted by the duodenal mucosa. So another of the sphincter, that is sphincter pancreaticus. Sphincter pancreaticus. And these, most of the occasion, these together they open into the second part of the duodenum, and they are guarded by another sphincter, that is sphincter of Oddi. Sphincter of Oddi. These sphincters are names. They are very, very important when you are a PG examination. They may ask what is Boyden, what is Oddi. Like this, they may ask what is the pressure. All these things. Here, if there is at this during contraction of this gallbladder, the pressure increases up to 25 millimeters of mercury. Then only the secretions are entering the second part of the urine. Okay, that is the importance of the sphincters which are guarding the pancreatic duct and bile duct. Okay, next coming to the Calot's triangle. Okay, the way you're supposed to know about the Calot's triangle, this is also very, very important. It is roughly a triangular space bounded inferolaterally by the cystic duct, spirolaterally by the inferior surface of the segment 5 of the liver, and medially by the common hepatic duct. In between these three boundaries, there is a triangular space. This triangular space, like this, is a triangular space. This triangular space is called Calot's triangle. What are the contents of the Calot's triangle? That is very, very important. Clinical. Here, the Calot's triangle contains a cystic artery, and usually the cystic artery is a branch from the right hepatic artery, and two small cystic veins, and cystic lymph node, and sometimes there may be accessory hepatic ducts. Here, usually what happens, from the liver, the bile enters into the through the common hepatic duct, then it enters into the gallbladder. That is the normal path. But in some occasions, directly from the substance of the liver, directly from the liver parenchyma, that small accessory hepatic ducts, they may directly drain into the gallbladder. That is, they are called accessory hepatic ducts. These are the contents. That is cystic artery, two small cystic veins, cystic lymph node, and accessory hepatic ducts. These are the very, very, very dangerous structures. If there is a presence of the accessory hepatic ducts during the removal of the gallbladder or during the cholecystectomy, that is removal of the gallbladder, these accessory pancreatic, there is hepatic ducts, they may pour the secretions into that area, and that is because it is highly corrosive. The bile is highly corrosive in nature. It may corrode, it may eat off the surrounding substance, and it may cause its own manifestations. It may produce a peritonitis and formation of abscess. That is why the accessory pancreatic hepatic ducts are very, very important thing. These are the structures which are present in the Calot's triangle. Here, what is the importance here? While removing the gallbladder, you must take care about the cystic arteries, cystic veins, and accessory hepatic ducts. Otherwise, it leads to its own clinical manifestations. And I had an experience. When I was a resident doctor, duty doctor in Nellore, Biliary super special hospital, there was one doctor, that is Dr. Roop Kumar. He is a famous surgeon, especially he is ex-military, and he is working as a doctor. He is a specialist in doing laparoscopic surgeries. But he developed cholecystitis He underwent cholecystectomy. Dr. Mallikarjun Reddy is a urologist. Now he is in Apollo Hospital. He did cholecystectomy operation, but because of damage to the cystic duct or damage to the right hepatic duct, he developed leaking of bile. Or because of the accessory hepatic ducts, he developed leaking of bile continuously. For this purpose, you have to put the drain continuously. You must drain the bile which is secreted into the Calot's triangle, this apparatus. Otherwise, it may cause peritonitis and use of the surrounding tissue because it is highly corrosive. That is why you must be very careful with these structures while doing cholecystectomy or removal of the stones or during any malignancy or any tumors which are related with the hepatis. You must be very careful. That is why this Calot's triangle is, examination point of view, is also the Calot's triangle. They may ask for the key marks. You see here, boundaries of the Calot's triangle. You see, this is the Calot's triangle. Here above, it is by the superior-laterally by the fifth segment of the liver, and inferior-laterally by the cystic duct, and medially by the common hepatic duct. Okay, you see here, this is the original picture. You see, this is the hepatic artery. This is the common hepatic duct. Okay, this is the one bile duct. This is the right hepatic, left hepatic duct. This is the right hepatic duct. Together they form the common hepatic duct, and this is the cystic duct. So this area is the Calot's triangle. This is the fifth segment of the liver, and this is the cystic duct. This is the common hepatic duct. Okay, this is the Calot's triangle. That is why this Calot's triangle is very, very important in the extra-hepatic biliary apparatus. Okay, here there is chances for the formation of cancerous tumors and the formation of stones in the gallbladder. They may obstruct in the neck of the gallbladder, or sometimes they may obstruct the CBD, common bile duct, or sometimes most of the occasions they obstruct at this level because it is narrow. Here, this level it may be obstructed and it produces its own manifestation, that is nothing but the obstructive jaundice. You know already, I think already we discussed, in the biochemistry, that is jaundice, that is of three types, that is obstructive jaundice, right, hepatic jaundice, and hemolytic jaundice. Out of these, the obstructive jaundice, it is more common in the obstruction of the gallbladder or obstruction of the common hepatic duct is the most common site. Okay, that is about the extra-hepatic biliary. Okay, we can discuss further, but there is no time. Okay, next we go for the another topic, that is the important points I am touching. Okay, you have to read in detail. If you have any doubt, when after coming to the college, you can clarify your doubts. Okay, thank you. Next section is the diaphragm. Diaphragm, especially the thoracoabdominal diaphragm. The diaphragm is a dome-shaped musculo-apparatic partition which intervenes between the thorax and abdomen. The diaphragm forms the roof of the abdomen. Okay, you see here, this is the thoracoabdominal diaphragm. Okay, it is a musculo-apparatic structure. It divides the trunk into two parts. Upper part is the thorax, lower part is the abdomen. That is why it is called thoracoabdominal. Like there are different diaphragms in the body. Here, this is the thoracoabdominal diaphragm. The peripheral part of the diaphragm is muscular. The central part is abdominal. It is also called central tendon of the diaphragm. Okay. Here, the diaphragm, what are the structures which are giving origin to the diaphragm? The diaphragm, it is taking origin from the three important structures. First, we have to divide the diaphragm into origin of the diaphragm into three parts. That is, first one is the sternal origin. Next is the costal origin. Next is the vertebral origin. Okay, the origins of the diaphragm we are dividing into three parts. One is from the sternal origin, that is from the posterior surface of the Jiffy sternum. You see, this is the Jiffy sternum. From here, these are all the sternal fibers. That is posterior surface of the Jiffy sternum. And next part is the costal origin. That is the lower 6 costal cartilages and ribs. Ribs and costal cartilages. They are also providing origin to the diaphragm, especially the muscular part of the diaphragm. It is taking origin from the costal cartilages and ribs of lower 6. Lower 6. That is the costal origin. Next, here the costal origin they interdicate with the transverse abdominis. Transverse abdominis muscle. Okay, next is the another origin, that is a vertebral arch. Vertebral arch. Okay, from the vertebral origin, there are again the vertebral origin of the diaphragm. It is divided into 3 parts. First thing is the crus, that is the right crus and left crus. The right crus it takes origin from the bodies of the upper 3, that is first, second, and third lumbar vertebrae, because it is stronger, because it is supposed to lift the weight of the liver during respiration. During respiration, that is why right crus of the diaphragm is stronger when compared with the left crus. Here, the left crus of the diaphragm it takes origin from only upper 2 lumbar one, that is L1 and L2. It takes origin from the L1 and L2. Okay, so these origins we call it as crus. Right crus and left crus together they join and they form the arch. Okay, tendinous arch. Tendinous arch. Below this tendinous arch, there is one opening that is nothing but the aortic bone. Aortic bone. Okay, that is the origin. Next, another part that is from the medial and lateral arcuate ligaments. Medial and lateral arcuate ligaments. This is the medial arcuate ligament. This is the lateral arcuate. You see what is the medial arcuate ligament? This medial arcuate ligament is nothing but the thickened fascia that is covering. It is covering the psoas major muscle. It is also called psoas fascia. Psoas fascia. The thickening of the psoas fascia it takes part in the formation of the medial arcuate ligament. Medial arcuate ligament. It is providing origin to the fibers of the diaphragm. And here the medial arcuate ligament, medially it is attached to the body of the L1 or L2, and laterally it is attached to the transverse tip of the transverse process of the L1. Tip of the transverse process of the L1. Okay, this is the medial arcuate ligament. Next, another one is the lateral arcuate ligament, also giving origin to the diaphragm. That is here the lateral arcuate ligament. It is nothing but the fascia, that is a fascia transversalis, that is thoracoabdominal fascia, that is a thickening of the muscle, the fascia which is covering the quadratus lumborum muscle. Quadratus lumborum muscle, thickening of the fascia. Here the lateral end is attached to the tip of the first rib, the first costal cartilage, first vertebra, L1 vertebra. Laterally it is attached to the lower border of the 12th rib. Laterally it is attached to the under surface of the lower border of the 12th. Okay, here this is the lateral arcuate ligament. This is the medial arcuate ligament. From these two ligaments also, the diaphragm taking origin. Diaphragm taking origin. So these are all the structures which are giving origin to the diaphragm. All these fibers they go towards the center, and then they form the apparatic structure. This is nothing but the central tendon of central tendon of. And within that diaphragm, there are 3 major openings and many small minor openings. The major openings are, you see, this is the opening for the inferior vena cava, and this is the opening for the esophagus, and this is the opening for the aorta. Okay, abdominal aorta passes through the aortic opening of the diaphragm, then it continues as the thoracic aorta passes through the diaphragm, then it continues as the abdominal aorta. Okay, here first you see aorta, inferior vena cava opening. Inferior vena cava opening is in the right part of the central tendon of the diaphragm. That is at the level of the TH, at the level of the TH, or this between the T8 and T9. At this level, this is the vena cava opening. Vena cava opening. This vena cava opening is quadrangular in shape. Quadrangular in shape, and the periphery of the vein is attached to the diaphragm. Periphery of the inferior vena cava is attached to the diaphragm. Because of this reason, whenever if you take respiration, diaphragm moves down and there is a dilatation of the inferior vena cava. Dilatation of the inferior vena cava. It allows more blood to enter into the right atrium. More blood enter into the right atrium. That is the importance of the inferior vena cava. That is at the level of the T8 or this between the T8 and T9. Next, another opening, that is the, it is quadrilateral in shape, but here it is elliptical shape. It is slit-like because it is present in between the muscle fibers of the right crus of the diaphragm. Right crus of the diaphragm. It is elliptical in shape. Usually it is closed. Usually it acts like a wall. It acts like a wall, and it prevents regurgitation of gastric contents into the esophagus. Gastric contents into the esophagus. Here, because of this reason, inspiration and swallowing is not possible. Inspiration and swallowing is not possible simultaneously. That is because the diaphragm it closes during inspiration, it constricts. Then you are unable to take food while inspiring. That is the importance of this esophageal opening. It is at the level of the T10. It is at the level of the T10. It is elliptical in shape, and this is the esophageal opening of the diaphragm. Next, come to the another opening, that is a aortic opening. Aortic opening, that is at the level of the T12. It is at the level of the T12. Okay, it is formed by the arch fibers of the two crusts of the diaphragm, right and left crust, right crust and left crust of the diaphragm. Together they form the arched fibers. And here, because of this reason, it is surrounded by muscular. This is aponeuritic. It is elliptical shape. It is quadrilateral shape. And here it is osteoaponeuritic. Here below this aortic opening, there is a body of the 12th thoracic vertebra, and above there is a aponeurosis. Here through this opening, the thoracic aorta passes, and then it continues as the abdominal aorta. Along with this, that is thoracic duct. Thoracic duct also passes to this aortic. Okay, these are all the major openings, and there are small openings, that is between the sternal origin and this postal origin. There is a small area through this, the internal thoracic artery divides into two. That is a superior epigastric artery. Superior epigastric artery passes, and then in between the origins of the postal origins, and they interdigitate with the origins of the transverse abdominis. In between these origins, there are interpostal vessels and nerves. They pass into the diaphragm. Then there are some other small. There is a small opening for the phrenic nerve and phrenic nerves. Here, the phrenic nerves are the main or motor nerves of the diaphragm. And the peripheral part, it also receives from the intercostal nerves, and it also receives the nerves from the sympathetic chain. Okay. The next, blood vessels which are supplying to the diaphragm. Here there is supraphrenic and infraphrenic, and pancreatico, pericardico, phrenic nerve arteries. There are also supplies, and intercostal nerves, intercostal arteries. They are also supplied, and there are two arteries. That is inferior phrenic artery and superior phrenic artery. They are nothing but the branches from the abdominal aorta. The superior phrenic artery, it is the last branch of the thoracic aorta, and the inferior phrenic artery is the first branch of the abdominal. Okay, these are all the structures they are supplying to the diaphragm. And if sometimes there will be chances for the defect in the development of this part, especially the sternal part and the costal part, if there is a persistence of this opening, this is called foramen of Margogni, and it may cause hernia. Or sometimes Bagdolak's triangle, that is in the posterior, is a right crus of the right crus and the postal origins. If there is a gap in this area, Bagdolak's triangle, we call it as, if there is any defect in the development of this triangle, closing of this triangle, it may lead to also hernia. They are all called diaphragmatic hernias. Okay, that is about the diaphragm. Okay, You see here, these are all the openings. This is the inner wall opening, this is the aortic esophageal opening, and this is the aortic. This is the, these are the muscles. That is, this is the psoas major, this is the quadratus lumborum, and here this is the lateral arcade ligament, this is the medial arcade ligament, this is the right crus, this is the left crus, and this is, these are all the subcostal vessels and nerves. Subcostal vessels and, okay, these are all the structures present in the diaphragm. In brief, okay. Next, coming to another important topic, that is peritoneum. 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 You can see here, this is the condition, clinical condition. This condition is called ascites. That is a collection of fluid, abnormal fluid collection in the peritoneal cavity. We call it as ascites. Here, due to ascites, you see the veins, prominent veins, and here the umbilicus is also protruded. Umbilicus is also protruded, and this is the clinical condition ascites. That is abnormal. Usually, there is a thin film of fluid in the peritoneal cavity to provide or to prevent friction, to provide easy movement or free gliding movements of the intestines. But if there is any abnormal collection, that is due to some abnormal pathology, it leads to its own manifestation. That is nothing but the ascites. Here, first you see what is peritoneum. The peritoneum is the largest serous sac which lines the abdominal parietes and is reflected over the viscera to invest them partially or completely. Partially or completely to invest the abdominal parietes. There is a layer that is nothing but the peritoneum. The peritoneum, suppose it is covering the viscera, we call it as visceral peritoneum. If it is covering the only body cavity, abdominal cavity, outside the abdominal cavity, we call it as parietal peritoneum. Just like our visceral pleura, parietal pleura, or pericardium, visceral pericardium, parietal pericardium. Like that, here also visceral and parietal peritoneum. Okay, the parietal peritoneum and visceral peritoneum, developmentally and functionally, they are different. Suppose if you take visceral peritoneum, that is developed from the splagnopluric layer of the lateral plate medulla. Because of this reason, it is supplied by the involuntary nerves or autonomic nervous system. And if you take the parietal peritoneum, it is developed from the somatopluric layer of the lateral plate medulla. Because of this reason, it is supplied by the somatic nerves. Somatic nerves or voluntary nerves. Voluntary nerves. Because of this reason, the parietal peritoneum is pain sensitive and visceral peritoneum is pain insensitive. Okay. Next, you see the peritoneal cavity. It is divided into different segments. Different segments. For our convenience, we are dividing the peritoneal cavity into different segments. Basically, you see, this is the root of the mesocolon, and above the root of the mesocolon, we call it as this compartment is called supracolic compartment. Supracolic compartment, and below this is the infracolic compartment. Again, infracolic compartment, which is within the pelvis, through pelvis, that is called pelvis. Okay, and the infracolic compartment, again, it is divided into two parts. That is right and left parts. Right and left parts by the root of the mesentery. By the root of the mesentery, it is divided into two parts. That is right and left infracolic compartments. Right and left infracolic compartments. Here, the supracolic compartment. Basically, the total peritoneal cavity is divided into two parts. That is lesser peritoneum and greater peritoneum. Lesser peritoneum and greater peritoneum. Okay, and lesser peritoneum is a very small area, the red colored area. This area is called lesser peritoneum, or it is also called omental bursa. It's also called omental bursa. The remaining green colored area totally is the greater peritoneum. Greater peritoneum. Okay. The lesser peritoneum, it is in the behind the stomach, and behind the lesser omentum, very small area. It is having communication with the greater peritoneum through the small opening. This is nothing but the epiploic foramen. Through the epiploic foramen only, the lesser peritoneum is connected with the greater. Here, the supracolic compartment of the greater peritoneum, again, it is divided into different recesses, different recesses. Again, this part is divided into two parts. That is supra-hepatic compartment and infra-hepatic compartment. Because of the presence of the liver in the upper part, it is above the liver, these small areas they are called supra-hepatic parts. And below the liver also there are areas that are called infra-hepatic parts. Apart that is, under all these areas, there are the spaces, peritoneal spaces, which are related with the liver. They are all called different names. That is anterior recess of the peritoneum, posterior recess of the peritoneum. Okay, right posterior, left posterior, right anterior, left anterior. And there are two other recesses, that is extra-peritoneal recesses. Extra-peritoneal recesses, that is behind the biliary area of the liver, there is a right extra-peritoneal recess. Behind the biliary area of the stomach, there is a left extra-peritoneal recess. Like that, there are 6 recesses surrounding the liver and stomach, that is in the supracolic compartment. Supracolic compartment. Out of these two recesses are very, very important clinically. That is, one is right posterior recess. Right posterior recess. This is very, very important because this is also called Morrison's pouch. Morrison's pouch. And because this is the most dependent part of the supraperitoneal, colic compartment of the peritoneal cavity. When lying down, right? Lying down, this is the most dependent portion. That because of this reason, any collection in the supraperitoneal compartment of the supracolic compartment of the peritoneal cavity, it accumulates in the Morrison's pouch or right posterior hepato. This is also called hepatorenal pouch of Morrison. Hepatorenal pouch of Morrison. That is why hepatorenal pouch of Morrison clinically it is very, very important. Because it is the most dependent part. Suppose if there is any perforation of the stomach or duodenum or anterior part of the stomach and duodenum, there is chances for the spilling of these secretions, these contents of the stomach or duodenum into this Morrison's pouch or hepatorenal pouch of Morrison. Okay, that is why this is clinically very, very. What are the boundaries of this Morrison's pouch? And it is also very, very important. Okay, next another important that is lesser omentum. Lesser omentum, it is nothing but it is also taking part in the formation of the left posterior recess, peritoneal recess. Left posterior peritoneal recess. If there is any perforation of this gastric contents, that is the perforation of the stomach due to peptic ulcers. Peptic ulcers are some injuries or some acids may cause erosion of the gastric mucosa. The contents of the stomach leaks into the lesser omentum. That is nothing but the posterior, right, left posterior recess. Then they may go through the hemiploic foramen into the Morrison's pouch. And then the Morrison's pouch it is connected with the pelvic cavity. Okay, like that, there is a chances for spreading of all this infected material throughout the peritoneum. And it produces clinical condition. It is called generalized peritonitis. Generalized peritonitis. That is the danger with the perforation of gastric ulcer or perforation of the duodenal ulcer. Duodenal ulcer. Due to ulcer development or due to some taking some corrosive substance. Corrosive substance. That is the problem. Suppose if you take another perforation, that is ileal perforation. Ileal perforation, that is mostly it is in the infracolic compartment. Infracolic compartment. Not in the supracolic compartment. The supracolic compartment perforations are more common in the gastric perforations and duodenal perforations. That is why the pouch of Morrison's pouch, there is a hepatorenal pouch of Morrison, and the posterior, left posterior recess of the peritoneum. These are two very, very important. The remaining are not much important. Okay. Next here, the root of the colon, the roots of the mesentery, it divides the infracolic compartment into right and left part. Right part is triangular, it is closed. It is closed on all the sides. But the left part, left inferior part, infracolic compartment, it is communicated with the pelvis. It is communicated with it is open below. It is communicated with the pelvis. If there is any collection in this area, it may gravitate into the pelvis and it is collected in the another pouch That is, suppose if you take the female, that is a recto-uterine pouch. Recto-uterine pouch, that is pouch of Douglas. If you take a male, that is recto-vesical pouch. Recto-vesical pouch. These are the two pouches. They are the most dependent parts of the peritoneal cavity. Most dependent parts of the peritoneal cavity in the pelvis, especially the infracolic compartment, especially the left infracolic compartment. You see here, this is the recto-vesical pouch in the male. Okay, here these are all the, you see, this is the lesser omentum, a lesser sac, and this is the lesser omentum. This is the greater omentum, and these are all the there is a folds of the peritoneum, especially they are covering the liver. There is a triangular ligament, coronary ligaments. Okay, here it takes part in the formation of the falciform ligament, and here this is the lesser omentum. The anterior layer of the lesser omentum, it is formed by the greater omentum, greater sac peritoneum, and the posterior layer is formed with the lesser sac peritoneum. And here you see another ligament. This is the transverse mesocolon. Here also it is a lesser sac peritoneum. This is the greater sac peritoneum. Okay, like these are all the folds which are covering the intestines, different parts of the intestines. And here, if it is covering the, it is connecting the mesentery, colon, small intestine, we call it as mesentery. If it is connecting the colon, that is called mesocolon. And if it is connecting the sigmoid colon, sigmoid mesocolon. Sigmoid, depending upon the, and here this is the greater omentum. Here the greater omentum, the anterior layer, it is first layer, it is formed by the greater sac peritoneum, and second layer is formed by the lesser sac peritoneum. Third layer also lesser sac peritoneum. Fourth layer is formed by the greater sac peritoneum. Okay, like this, these are all the different folds of peritoneum. And this is the horizontal disposition of the peritoneum. And here you see, this is the stomach, and this is the spleen. Here, this is the gastrosplenic ligament. You see, in the gastrosplenic ligament, the anterior layer it is formed by the greater sac peritoneum, and posterior layer is formed by the lesser sac peritoneum. And here, rhino-renal ligament. The posterior layer here it consists of the anterior layer, and here this is the surrounding this spleen. Then it consists of the posterior. Like that, these are all the different folds of peritoneum. They are connecting the different parts of the abdominal cavity. Okay. Here, this is the epiploic foramen. This is the only communication between the lesser sac and the greater sac. This is the only communication between the greater sac and lesser sac. That is why, in your examination point of view, this epiploic foramen is very, very important, and lesser omentum is also very important. Lesser omentum and greater omentum. They may ask for the short answers. Lesser omentum and greater omentum. Okay. These are all the different folds. Next, you see, if you lying down condition, these are the most dependent parts of the peritoneal cavity. Most dependent parts of the peritoneal cavity. You see, this is nothing but the hepatorenal pouch of Morrison. This is the kidney. This is the liver. Okay, this is the hepatorenal pouch of the Morrison's or Morrison's pouch or hepatorenal pouch of Morrison. And next, this is the infracolic compartment, and this is the pelvic cavity. And okay, these are all the, this is the watershed line. Pelvic brim is the watershed line. Acts like a watershed line. Okay, these are all the, and again, for our convenience, we are dividing the peritoneal cavity into, again, vertically, we are dividing into different parts. That is a paracolic ductus. You see, this is the ascending colon, here transverse colon, then this is the descending colon. On both sides of this ascending colon and descending colon, these areas they are called paracolic ductus. Para means side of the colon. There are grooves or depressions. They are called paracolic ductus. This is the right paracolic ductus. This is the left paracolic ductus. Okay, like that. These are all the paracolic ductus. Okay, like that. There are different segments in the peritoneal. Okay, these are all very, very important. Here, there is any inflammation or infection due to any perforation or any injuries, abdominal injuries, or due to typhoid, uncontrolled or untreated enteric fever or typhoid fever, it may also lead to biliary perforation. Biliary perforation at the level of the phase patches, and it may produce generalized peritoneum. Generalized peritoneum. Okay, and here the peritoneal cavity is also very, very important. Previously, before hemodialysis, we used to do peritoneal dialysis, feeding, because the peritoneum, it is a mesothelial layer. It is having capacity to absorb, it is having capacity to secrete. It secretes the and it absorbs the substances, especially the nitrogenous waste products and urea, ammonia. These are all secreted into the peritoneal fluid. Because of this reason, we used to give dialysis fluid into the peritoneal cavity. We retain the fluid in the peritoneal cavity for about 45 minutes. Then we drain the fluid. By this way, we are able to remove the waste products, nitrogenous waste, metabolic waste products from the body in this way. But nowadays it is replaced by HD, hemodialysis. That is another important use of this peritoneum. And if there is any abnormal collection, that is due to cirrhosis of the liver or hypoproteinemia or due to congestion, portal congestion, that is congestion of the intestinal blood vessels, congestion of blood, stagnated blood in the intestinal vessels. It leads to leaking of fluid into the peritoneal cavity. The condition is called peritoneitis, or it may be due to heart failure, especially right heart failure. It leads to development of ascites and hypoproteinemia. Hypoproteinemia is also one of the most important cause for the development of the ascites. Because of all these reasons, there is a chances for the accumulation of fluid in the peritoneum. Usually, there is a very thin film of fluid. To prevent friction, to facilitate lubrication. But if there is any abnormal collection of this fluid, we call it as ascites. Here, if the fluid is more than 1500 ml, then usually it produces bulging of the abdomen. Before that, it is very difficult to identify the ascites. Okay, the most common cause is cirrhosis of the liver. It is more common in the alcoholic. It may develop in the non-alcoholic also, but alcoholics are more prone for the development of the cirrhosis of the liver. Another important thing, the peritoneum, it also facilitates the ovulation. That is the carrying of the ovum from the ovary to the fallopian tube. Sometimes there is transcoelomic migration. The transcoelomic migration means that is the ovum, it is produced by the left ovary. It may be attracted by the right fallopian tube. That is nothing but the transcoelomic migration. Okay, these are all the functions of the peritoneum. Okay, with this we conclude. Okay, that is about the peritoneum, diaphragm, and extra-hepatic. These are all three topics are clinically very, very important. Clinically, and an examination point of view also very, very important. Okay, you study carefully. If you have any doubt, you clarify after me. Okay.